I really enjoyed this interview with Dr. Andrew Spector. He's a sleep neurologist, he specializes in RLS, and he shared so many clinical pearls that you will not want to miss, including classic triggers for RLS, how to properly work up iron, and the ferritin levels to look out for. And you may be surprised by what he has to say. He also talks about the new treatment guidelines, and it's completely different from what has been standard practice for the last couple of decades, so you won't want to miss that. He shared so many pearls with regard to medication strategies, dosing, non-pharmaceutical strategies, and so much more. This is a jam-packed episode. Dr. Spector was so generous with his knowledge and expertise. You'll want to watch all the way to the end. Take notes as you go along, so pull up a Google Doc or grab a pen and paper because there are so many pearls shared in this conversation. Watch the video and then let me know in the comments below what were your biggest takeaways from this discussion. Let's jump in. Today we're talking about treating restless leg syndrome with Dr. Andrew Spector. Dr. Spector is the Sleep Medicine Fellowship Program Director at Duke University, and he's the Duke Athletics Sleep Optimization Consultant and the author of Navigating Life with Restless Leg Syndrome. If you are a physician who wants to learn more about sleep medicine, go ahead and subscribe to this channel. I'm Dr. Nishi Bhopal. I'm a physician specializing in integrative psychiatry and sleep medicine. And a quick note for clinicians, if you ever use melatonin with your patients, you can get my free melatonin brand guide at intrabalance.com/melatonin. It's your guide to third-party tested high-quality melatonin supplements. All right, Dr. Spector, thank you so much for joining me today. Could you tell us a bit about your clinical background and what you do?
Absolutely. Thank you so much for having me. I'm a neurologist by training, and I kind of gave up my general neurology practice, focus entirely on sleep medicine in the clinic now. For the last 6 or so years, I've been doing exclusively sleep medicine here at Duke. I do some administrative things, like you mentioned, on the side with the program fellowship, but my clinical practice is the breadth of sleep medicine, restless legs, and all the rest too.
So how did you transition full-time from into sleep medicine from neurology? What sort of prompted you to do that?
So sleep has been my passion forever. I went to med school with the idea I wanted to be a sleep doctor. And I know that sounds crazy, but ever since an undergrad, sleep medicine was it. And it was really a question of what route did I want to take? Because there's so many ways to get into sleep medicine. And neurology was my favorite, but my long-term goal was always sleep medicine. And then as the opportunity to do some administrative roles within Duke came up, if I had to reduce my clinical time, it was always going to be the general neurology side I was going to choose to reduce because I wanted to hang on to as much sleep medicine as I could.
It's so interesting. You knew you wanted to be a sleep doctor when you went into med school. Yeah, it's always interesting to hear other sleep doctors' sleep stories. Was there a patient that you saw that kind of, motivated you to do that, or was it
This
a
was
personal experience?
undergrad. This was
Right.
freshman year, spring semester, Psych 101, Psych Intro Psych. There was a unit on sleep and dreaming as part of psychology course, and I just said, wow, this is really cool. I wonder if I could make a career out of this. And then it took me a little time to figure out how, but eventually I figured out there is a thing of sleep medicine that I didn't know about as a freshman in college. But once I figured it out, I knew that's what I wanted to do.
It's such a fascinating field. I mean, that was one of the things that drew me towards sleep medicine is there's so many different facets to it. And I mean, you're a neurologist, I'm a psychiatrist by training. You can go into it from pulmonology, pediatrics, like it truly is a multidisciplinary specialty.
And I was a psychology major. I like psychology. I thought maybe I wanted to be a psychologist, a counselor, and sleep medicine is a way you can do that. I mean, there's a lot of psychology that I do in my practice in sleep. So it's a great way to integrate that into my medical practice.
Fabulous. And one of your areas of expertise is restless leg syndrome. You wrote a book about it. So what prompted you to do that? What was it about RLS that you felt needed to be talked about more?
Yeah, so restless leg syndrome is, I think, under-recognized for the degree of problem it is. If we look at the epidemiology, it affects over 10% of the population. So it is a huge problem. And it often goes either under-recognized, underappreciated, undertreated. And then the other set of people get treatment, but often that treatment may be making them worse. And so we've got two groups of people who are suffering, the undertreated and the overtreated. And then when you do get them on appropriate therapy, their quality of life is so much better that it becomes a really rewarding area to treat. And I really just enjoyed being able to help those people who've been suffering, many for decades, with this condition. And sleep medicine in general is one of those fields where you can make a huge difference in quality of life in any of them. But restless legs, I felt like was a sort of an underappreciated niche that needed some more attention.
Absolutely. I agree with that. And we were chatting a bit before we started recording about how, well, first of all, doctors don't get much training in sleep medicine unless they go into sleep. And a lot of patients in the community are seeing their primary care physicians for RLS management, or maybe they're psychiatrists or neurologists or non-sleep trained clinicians. And the treatment I've seen in the community is kind of all over the map. So I think there's a lot of misconceptions about how to effectively assess and treat restless leg syndrome. So, could you share a little bit about some of the signs and symptoms of restless leg syndrome that clinicians should be on the lookout for?
Restless leg syndrome is relatively easy to diagnose in reality, mostly because it's a clinical diagnosis based pretty much on what the patient says. So the criteria are an irritable, uncomfortable, unpleasant sensation, usually in the legs, and often described as an urge to move, not typically painful, but uncomfortable nonetheless. That gets worse in the evening, later in the day, worse when resting or sedentary, and better when up and moving. And also, the classic caveat, not better explained by something else.
Right.
But generally speaking, those are the four criteria. No testing needed. If the patient fits, you can make the diagnosis. So it's a relatively straightforward clinical diagnosis you can make based on what the patients are telling you.
Is there a questionnaire or some sort of an intake form that, a primary care doctor or psychiatrist can include in their paperwork to screen for it?
So when we screen at Duke, we just ask those four questions, right? Because it's only the four. So you can ask, do you have that? You're uncomfortable, need to move? Does it get worse when you're sedentary, et cetera? So we do ask those as a part of our sleep medicine intake. Honestly, I don't anticipate something in primary care or, adding those particular questions. For that group, I would say, how do you sleep is sufficient. Just ask about sleep. Start the conversation. And if patients can't sleep because they have restless legs, they will tell you. And they'll be very open. I can't sleep because I have restless legs. So the quick screening in the primary care setting is simply to ask the question, how are you sleeping?
Great. Yeah, I agree with that. I think it's such a powerful thing that's often missed. It's simply asking patients about sleep. And I'll just add a quick little sort of tidbit for the clinicians, which is that restless leg syndrome can present like insomnia because patients will say they have trouble falling asleep or they have trouble getting comfortable. And what I've sometimes seen is that now they're put on this treatment path for insomnia when the restless leg isn't really being addressed or looked into.
And that's a great point because if somebody says, I don't sleep well, the next question has to be, why not? Because they'll often know. I mean, the patients will tell you what the problem is if you ask the follow-up, as opposed to reflexively, oh, you're not sleeping well, here's a sleeping pill, right? You're missing the cause. And when you get to the root of the problem, you can treat it much more effectively.
Okay, so now we have a diagnosis of RLS. What's the next step in treatment? And there's new treatment guidelines that have come out recently. So yeah, so could you give us some more information about that?
Right. So we'll definitely get to those guidelines because it is a big difference from the 2012 guidelines. So it's really important to understand the change. But before we even get to things like pharmacotherapy, number one thing is look for triggers. Right? There are classic triggers for restless leg syndrome: antihistamines, SSRIs, anything anti-dopaminergic, like the antipsychotics or nausea medications that are anti-dopaminergic. Those are all triggers to look at. And then there's alcohol, caffeine, tobacco, sugar, four substances that can all trigger restless legs. So goal number one is what can we clean up? And even untreated sleep apnea can provoke restless legs. So when we want to make sure that the triggers are addressed first. Next step is iron. And we can't miss the iron. Iron is critically important to treating restless leg syndrome. And one of the things that I need to get across is that when you get an iron test, the lab is going to give you a normal value that's calibrated for how much iron you should have in your blood. But realistically, with restless leg syndrome, we don't care how much iron is in the blood, we care how much iron is in the brain. And those are two separate pools of iron because the blood-brain barrier divides it. And we don't actually directly measure the spinal fluid ferritin levels. So there is a conversion between blood iron and brain iron, which means just because the blood iron levels are coming back normal doesn't mean it's sufficient for a patient with restless leg syndrome. Ferritin greater than 100 is the new guideline. So normal is anything above 11. In restless legs, ferritin greater than 100 is the goal. And we also looked at the percent transferrin saturation because ferritin is an acute phase reactant. So you may see a high ferritin, but if that transferrin saturation is below 20%, then you can assume that's an inflammatory ferritin and still treat for iron deficiency. And that basic framework is a big change, I think, for the way a lot of people have been checking and monitoring iron and relying on the lab's normal values. And the lab normal values are just not helpful in this situation. Ferritin over 100, transferrin saturation over 20%. Either is too low and we treat.
That's so helpful. And I want to double click on that and go in a little bit deeper. Let's say I'm the primary care doctor. I have a patient in front of me. It sounds like they have restless leg. I want to check their iron levels. What's the best way to do that? Does it need to be fasting? Do we want them to hold supplements? Like, how would you go about the
Yeah.
testing?
I tell people to fast simply because you don't want a high iron meal or an iron supplement close to the time you're checking the iron. So definitely if they're on oral iron pills, they have to stop those probably 24 to 48 hours ahead of time. Doesn't technically need to be fasting, but I can tell them that way I know they're not getting any iron in their diet. Really, if they're avoiding, dark meat, chicken, and steak, you're probably going to be okay with this. But also, you want to check iron levels in the morning because that transferrin saturation has a circadian rhythm to it. So you want to consistently check in the morning. So basically, that's how we check them. Tell them to get the lab first thing in the morning when they wake up before breakfast is usually the optimal way to check iron.
Great. And we want to be getting a CBC alongside?
I don't, to be honest, because more often than not, it's normal. And the hemoglobin being normal doesn't tell me anything about the status of brain iron. So I don't check them.
Okay. Super helpful. Okay, great. We've looked at the triggers. We've looked at their iron status. What's the next step?
So if we decide that they have an iron deficiency, we should look at how are we going to fix that? Because again, until we get the iron levels in the brain to a sufficient level, they're not going to have good relief. So of course, there's oral iron and there's IV iron. We've got the two options. And I like to talk about why you might choose one or the other. The lower the ferritin, the better the patient will usually absorb oral iron. The gut is primed for this because they're so low. So I'll often start with oral for the lowest patients, which may be counterintuitive because you'd think, oh, it's really low, better dump it in. But they tend to have the best response to oral iron. Once you're looking at ferritins of 60, 70, 80, close to that target, but below, the amount that somebody's going to absorb is going to actually go down. And it's hard to get the really high levels of iron if you're starting from that middle zone of ferritin. So those patients, I usually will go with an iron infusion first. And once their ferritin's above 100, their gut's just not going to absorb much iron more after that. So you can't push them up very high with oral iron. So I'd go to an IV infusion. Also, if they've had bariatric surgery and you don't trust that they'll absorb it, if they've taken oral iron and it causes constipation or other GI side effects, I'm pretty liberal with the IV iron. It's much safer than it was 20, 30 years ago when I was in med school and they said it's very dangerous because of anaphylaxis. That product's not on the market anymore. The products we're using now, whether it's low molecular weight iron dextran, ferric carboxymaltose, ferriumoxetol, those products have very low risk of anaphylaxis, very effective. The only ones I don't recommend are iron sucrose or iron gluconate because they have different pharmacokinetics and they're not ideal for restless leg syndrome. But the others are all very effective and have a very low threshold because one iron infusion has very low risk and potential very high benefits for the patients.
Are you doing a follow-up ferritin level after a certain amount of time?
Yeah, so 8 weeks after an infusion, and if you check it before, you're going to get all kinds of crazy numbers from the infusion itself. Wait 8 weeks. And one of the reasons to do that, let's say the patient has a great recovery, the iron fixed them, and I get a lot of patients for whom that's sufficient treatment. But then you want to know, okay, well, what is that ferritin that worked? Because that way, if they start developing symptoms in the future, you don't need to wait for them to drop back down to a ferritin of 50. Right? If 300 is the ferritin that works for their legs and they drop to 200, I'm going for another infusion if they're symptomatic again, because I want to push them back above 300 because that we now know from that eight-week lab is the threshold we need to keep them at. So it's important to get that follow-up testing done to know your new baseline.
I think that's really important to understand what the patient needs, what's normal for them or what's
Mhm.
therapeutic for them, because it is going to be different from person to person. So there is that personalization of treatment that is required.
A lot of patients with restless leg syndrome have a mutation in the iron transport gene in the blood-brain barrier. And so without really high levels of blood iron, they don't effectively move the iron into the brain. So there are studies that are showing for every increase in blood ferritin, the spinal fluid ferritin barely reacts if you have restless leg syndrome, where it's much more strongly correlated if you don't have restless legs, because then you can move the iron efficiently into the brain.
With regard to oral iron, are there formulations of iron that you prefer?
Not really. I mean, I say generically ferrous sulfate, 325 milligrams, and there are all kinds of studies saying, okay, take it every other day, take it every day, take it at night, take it in the morning. And whatever you want to do, you can probably find some article that would support it. So I know a lot of people are saying every other day and at night, that's fine, but I don't really think there is so much overwhelming data that it has to be done that way. And I even don't even tell patients every other day. I just because I think it's really hard to remember to do things every other day. So I just say take it every day and assume they'll forget some of them, and then we'll be okay.
Are there any other pearls with regard to iron, or what would be the next step after that?
Yeah, so iron can get tricky, but I think those are the important points to get across today. That's a lot of iron information for one day. But next step, there's about a third of patients, I'd say, if they're naive to treatment and you get their iron up, that they won't need pharmacotherapy after that, about a third. But two-thirds still will, right? One third may have no response to the iron, and another third will have some response, but not enough to. And at that point, now we're really looking more at the guidelines for what are acceptable treatments. And this is where the big 180 change happened in the guidelines, which is historically the go-to has been dopamine agonists. Pramipexole and ropinirole, since the mid 2000s, have their FDA approval. So it's about 20 years of these drugs being first line, and the new American Academy of Sleep Medicine guidelines are discouraging use, say they're not recommended for standard treatment of restless leg syndrome. So the reason for that is because there is such a high rate of patients who take dopamine agonists who will develop a condition called augmentation. Augmentation is the worsening of restless leg syndrome in the setting of dopamine therapy. So now it may manifest earlier in the day. They used to have symptoms at 9 p.m., but now it starts at 8 and then 7 and then 6. Or it could spread to different parts of the body. So now it was restless legs, now it's restless legs and arms. So these are the types of things. So patients can get into a lot of trouble if the dose of the drug keeps going up and up, chasing the tail, trying to get on top of these symptoms. And it's really seductive because every time you go up on the dose, they're going to get relief until the cycle starts over and they get worse and worse. And then it becomes extremely hard to wean people off these drugs. They're so physiologically dependent on the drugs and to some degree psychologically dependent on them that getting people off dopamine agonists is a very challenging problem. So the AASM task force said, you know what, enough of these drugs, they're causing all kinds of problems. There may be a role for them in certain cases. I still use them sporadically for PRN therapy. There are roles for them, but they are not first line at all anymore for the standard daily use of treatment of restless legs. What is left? Gabapentinoids. Gabapentin, pregabalin, and gabapentin enacarbil, which is still brand name Horizon. It's the only one that's brand name only. Those are our go-tos now as first line. They're very effective, particularly in patients who have never been on dopamine agonists. Turns out if you've been on dopamine agonists and you have augmentation, the gabapentin drugs are not as effective. So best to start with them because you'll get more bang for the buck early than later. So that's first line.
So just kind of going through the sequence again, we've eliminated the triggers or reduced the triggers. We've dealt with the iron issue. Now we're going to the gabapentinoids. What sort of dosing strategies are we talking about here? And then what if they don't work? Then what?
So, right, there's certainly a population that just really doesn't respond to gabapentin. I mean, it's like taking a placebo for them. They really don't have any response. And then the others who are so sensitive to it, they can't tolerate it. So gabapentin gets a little tricky. My usual starting point is 300 QHS. So give them a 300 milligram pill. And I'm also flexible and give them 90 pills per month and say, start at 3. If you need to take 2, if you need to take 3, so be it. And I give them a lot of leeway, given the safety, the relative safety of gabapentin allows for that. So I usually prescribe at 300 QHS with the ability to self-titrate up to 900.
Great. Yeah. Okay. Excellent.
Pregabalin, I would start at 75 usually and give them one or two and give them 75 to 150 QHS.
Excellent. Are there other classes of medications that we should consider? And I know there's other treatments as well that are non-pharmaceutical, but
Right.
is there anything else in the pharmaceutical category that is commonly used or that is effective for RLS?
So there are two other commonly used medication. Well, I won't even say commonly used, but I would say recommended classes. One of them is common, and one of them is new and not commonly used yet. And that drug is dipyridamole. Dipyridamole is a drug that, as a neurologist, I used to prescribe for secondary stroke prevention. Back in my residency era, it came as a brand name drug called Agronox, and we used it. But it fell out of favor for stroke prevention because drugs like clopidogrel came along and it outperformed. So it went on the shelf. Until a couple of years ago, people said, you know what, in this pathway, this cascade of changes in the brain that occur in people with restless legs, one of the steps in the pathway is an adenosine problem. And this also, you may notice caffeine being a trigger. Caffeine's an adenosine antagonist, and that makes restless legs worse. They said, well, let's try an adenosine agonist. Dipyridamole was sitting there on the shelf, pulled it off, put it into a clinical trial. Lo and behold, it's actually really effective. And not only that, very well tolerated. I'm not using it first line, but I might someday because it is working pretty well on a decent number of my patients and is very well tolerated. It's slow acting though. So I've learned that you have to be patient with it. If you start people on it, I titrate slowly, not because of side effects, but because if you give them enough time, they might not need a dose increase. So 50, 100, 150, 200, those are all reasonable doses for dipyridamole. And it's also good as adjunctive therapy. If they need a second drug, but they don't want to go up because they're having side effects from gabapentin or something, add in some dipyridamole, and that may close the gap to their target level of relief. So that's one class that's really not used much, but I suspect it will be used more because it's in the guidelines now. And the other one is opioids. The way the guidelines phrase it is extended release oxycodone or other opioids. And that's an important distinction because the data, all the research seems to be focused on oxycodone. But those of us who treat a lot of restless legs use a lot more methadone and buprenorphine, for which there's not as much data. But the task force determined that this is a class effect of opioids, not specific to any one drug, and opioids in general are a highly effective class of medication for restless legs and only take a really low dose. So I have patients who get relief on just 5 milligrams of methadone. That's the lowest dose they make. It's very effective, and it's nice. It's long acting. You can take one methadone pill, and it lasts through the night, and often that's enough, and it's very effective, even for patients with augmentation.
Thank you for sharing all of that information. Okay, so what about non-pharmaceutical options? What's available?
The new kid on the block, let's say, just came out last year. It's a device called Nidra, and it's an electrical stimulator. It's a peroneal nerve stimulator specifically, which goes below the knee. So it's a band that you wrap around below each knee, and it's called TOMAC. TOMAC is tonic muscle activation. It sends a signal up the peroneal nerve to the spinal cord and triggers a spinal reflex that essentially, when I've worn them, I've tried them on, it feels almost like a vibration in the lower leg. And that can provide relief, particularly for those people who have their most symptoms in the lower leg. Because of where the bands are placed and the way they work, it's best for distal leg symptoms. So if you have your restless legs in the thighs and the back, probably not going to be for you, but it provides this sort of vibratory sensation in the legs. And the longer people use it, the better it seems to work for them. So it's exciting to have an option that is not a drug. It's exciting to have something FDA cleared. Medicare is covering this, so that's an option. Plus minus on commercial insurance at this point. Some don't, but Medicare does. So a decent number of our patients have been able to get it, and I'm having good success with it. It's not available in every state. The company is rolling it out state by state, although I've heard that by the end of 2025, they should be in every state. At this point, only a few states, and I'm lucky to live in North Carolina where we have access to it. But many people don't yet have access, but soon will.
Yeah, it's a really exciting option. I actually have one patient where I'm trying to get it for them, and we're going to test it out. What are some other non-pharmaceutical or maybe lifestyle interventions that can be helpful?
Moderate exercise is good. I mean, exercise is never bad for anything, right? It's always good to get exercise. In restless legs, if you go from not exercising a lot to exercising a lot, you will actually probably exacerbate the legs. But a moderate intensity exercise over the long term can actually improve restless legs. And the other things, variations on the same theme, which is what we call counter stimulation. So whether it's massage, pressure, heat, cold, whatever is stimulating the leg that sort of distracts the mind from the restless leg sensation can work. And I have people who accomplish that in a variety of different ways, but those are all different types of strategies like hot bath or massage. Those can help. And interestingly, the cognitive distraction is effective for some people. So watching TV is particularly bad because it's the least amount of, cognitive work. Doing a jigsaw puzzle is actually better. It's sitting up and doing something with your mind is better than just sitting there. So all these things can be effective.
Great. What about compression stockings?
Not a lot of my patients have gone that road. I don't know if it's because it's not dynamic enough. I've heard of people doing SCDs where they're like sequential compression, and that can help some people. But compression signs on their own, I haven't seen a lot of people get success from that. And then if we talk about supplements, the big supplement that everybody likes to go to is magnesium. And I say, okay, if it works for you. But if magnesium worked for most people, it wouldn't send me a lot of patients. They would have figured that out before they come to me. I don't put a lot of faith in magnesium supplements to solve this, although I certainly have had patients who tell me it works, and great, I'm glad it works for you, but I don't count on it.
So I have a sort of a theoretical question about, so I'm a psychiatrist, and many of my colleagues are psychiatrists, so they're seeing patients who are on SSRIs and they're stable on the SSRI, so maybe they have depression or anxiety and the SSRI is working well for them, but now they're having restless leg symptoms. What would you recommend?
I don't tell people to stop a successful, effective, otherwise well-tolerated SSRI. I just deal with the restless legs. And some of that's just prioritizing mental health. If they're doing well, let's not mess with that. The way I do address it is if everything is fine with your legs, and then someone comes along and adds an SSRI, and your legs get worse, then I'd say, all right, find another drug, right? Then we know, okay, that drug is triggering you, try to find something else. But if you come to me stable and happy, I'm not going to tell you you should stop that. I'll just deal with it. And on the scale of SSRIs are bad, but actually the data say that mirtazapine is the worst of them all for restless legs. So we'll throw that in with the SSRIs as a potentially problematic medication.
Great. Okay. Now this was so helpful. Thank you, Andrew, for sharing all this information. Can you tell us a bit about your book?
Oh, happy to. So the book is called Navigating Life with Restless Leg Syndrome. It's available pretty much anywhere. Amazon, Barnes& and Noble, or local booksellers can order it for you. And it's a patient guide. So I know that the audience for this discussion is mostly clinicians. And so what I would say is you have a patient come in with restless legs, let them know about the book, because that way it goes into some of the pathophysiology that they can understand, all their different treatment options. So this is written for them. And it goes through different scenarios. What if you're in the hospital? What if you have to have surgery? What if you're taking care of a patient with dementia who can't express what their symptoms are because they lose some verbal ability? So it goes through all different kinds of scenarios. There's a chapter specifically on pregnancy because restless legs is often worse during pregnancy. So we go through different populations like that. And then there's a special chapter for caregivers because this can get tough on caregivers. If the person with restless legs doesn't want to go to a movie, get on an airplane, like the spouse, the partner, the loved ones, they can pay the price for this too. They're sleeping next to somebody who's up and down all night. So I wanted to spend one chapter directly talking to the loved ones. So all this is in the book, and hopefully people find it helpful.
That's such a great resource. So I'll put the link to the book in the video description underneath this video so people can check it out. And I think it sounds like a great book for both for patients and for clinicians, because these scenarios do come up in clinical practice. So therapists, physicians can also use it as a guide to have these discussions with their patients.
Absolutely.
Um, and if people want to learn more about working with you, whether maybe someone wants to work with you one-on-one if they're a patient, or they want to invite you to come speak to their group, how can they contact you?
So all of this information is on my website. It's andrewspectormd.com, and that has speaker information. It also will link to my Duke website for clinical care. So all my clinical care runs through Duke. So they'd register as a Duke patient and make an appointment through that system. But for speaking or consulting on the side, all that information is on my website.
Amazing. Okay, and again, I'll put all that information in the video description below. So, as we wind down, what's one tip with regard to sleep that you'd like to share with our audience, whether it's a tip that you use personally or that you recommend to others?
I'll tell you my favorite sleep quote, and it's not mine, and I just wish I would have come up with it. I'm going to attribute the source to Dr. Sujay Konsagra, a pediatric sleep doctor here at Duke. Big presence on social media. Check him out. And he said my favorite thing ever about sleep, which is sleep is very important, but not important enough to lose sleep over. And
I love that.
that's right? It covers the people who don't sleep enough and the people who worry too much about their sleep. It covers both. And so I fully attribute that was his, but it's my favorite and it's my mantra now. So that's what I've got.
Excellent. And Dr. Consagra's social media presence is amazing. So if anyone wants to check that out too, highly recommended. We've got some fabulous sleep doctors out there like Dr. Spector. So thank you so much for joining me today, for sharing your knowledge. You were so generous with all the information. And yeah, I'm very grateful for you spending your time with me this morning.
Well, thank you so much for the invitation. I love talking about restless legs and I appreciate the opportunity.